Good morning, everyone. Thank you. It's the 1st of December 2025. This is the Health and Care Scrutiny Committee. Today, it's the first official day of Christmas, yay! And we've been brought a lovely report, so that's all our Christmas gifts all in one day. Do we have any apologies, Zach?
Good morning, Chair. I've received apologies from Councillor Adams and Councillor Parton.
Okay, we're just waiting for someone to arrive who I think is just here. Good morning. Okay, so do we have any declarations? No declarations? Okay, so we're to approve the minutes on the meeting held on the 10th of November 2025. Can I take these as accurate? Yes? Okay.
Just as a matter of horizon, can we not forget that we've got the site visit to WMAS to organise, which was in the minutes? Can that be carried forward?
Thank you for that, Councillor Rota-X. Okay. Okay, thank you. So today we've got the System Operational Plan from the ICB. And here with us we've got Claire Finn, we have Phil Smith, Dr. Rachel Galliot and Tracy Shewan. And then coming maybe on, hopefully by teams, would be Mish Irvin and Claire Skidmore, who haven't quite arrived yet, but I'm sure they'll be here soon. So I'd like to just hand over then to the ICB. Is there anything you'd like to say to us?
Pressing the wrong button. Good morning, everybody. Apologies for being slightly late this morning. So, yes, for those that don't know me, I'm Claire Finn. I'm the was the interim Chief Finance Officer up until yesterday. You'll be well aware that the ICB is going through some changes. So we've clustered with Shropshire, Telford and Wrekin, and the new executive team have come into post today. So Claire Skidmore is the substantive Chief Finance Officer as of the 1st of December. And no doubt my colleagues will introduce themselves in terms of their new roles as we go through the agenda. So you'll see within the paper there's the outline of the NHS ICB operating plan. So I will take the paper as read, but if I just run through some key headlines before we start the session. So every year, NHS England sets out the national priorities for the NHS for the year ahead, and that's what's detailed within the papers that you have. The paper outlines these asks, and we also were requested from the committee to ensure that we submitted all the documentation which has been made available to committee members. That includes all of the planning submission, all of the PIDs and associated QIAs, and anything else that went along with it in terms of the narrative submission and papers that went into board. So you will see that there's a significant amount of documentation that forms part of the planning process. But just to draw out in terms of some key priority areas. So NHS England published the national priorities at the end of January 2025. These broadly focused on the following areas: reduce the time people wait for elective care, improve A&E wait times and ambulance response times, improve access to general practice and urgent dental care, and also improve mental health and learning disability care. And we were asked to improve in these areas, but also we must live within the budget allocated, focus on reducing waste and improving productivity, maintain quality and safety, address inequalities within health, and also move towards the prevention agenda alongside a move to digital. So just in terms of where we got to with our planning submission, so our allocation as an ICB is circa 3.2 billion in 25-26, and this was an uplift from last year of about 85 million. We set as a system a planned deficit of 95 million, and we received from NHS England national team 95 million of deficit support funding. Our plan that we submitted was broadly compliant across all of our metrics and our targets. Given the asks set out by NHS England and the financial position, we've had to identify areas of spend where we of low clinical value, and also where we would want to actually refocus our priorities on our investment. So the efficiency value identified for the system was 306 million, of which 169 million related to the ICB. You will see from the papers that 55 million related to technical and planning items which do not require any changes to services. There was 5.5 million related to enhanced financial controls, 25.2 million relating to management cost savings, and then 83.8 million relating to 24 schemes where it was identified that there was either low value expenditure or where changes in processes could result in better outcomes at a lower cost. All of the schemes that have been taken forward have been developed with project initiation documentation, and as I said, associated quality impact assessments have been carried out to ensure that we understand all of the impacts. Just in terms of where we are then, in terms of the financial position, so at month 7, the ICB reported delivery of our plan, which is positive, and this was a 12.5 million deficit plan, but we were circa 10.3 million behind in our efficiency programme. You will see within the papers it references month 6, but I wanted today to provide the latest month 7 information for you. We are expecting our efficiency programme to catch up in the later part of the year and recover the shortfall that we've currently identified. I'll pause there. I'll just hand over to Phil in terms of anything that you would want to add in terms of the performance targets, and Rachel also.
Okay. Good morning, everybody. I'm Phil Smith, and similar to Claire, I've had a change in job title in the last 24 hours. So I was Chief Delivery, so the badge hasn't been updated yet, sorry. So I was Chief Delivery Officer for the ICB for the last 3.5 years up till yesterday, and then today I commence as Chief Officer for System Development and Integration, and this just reflects the changing role of the Integrated Care Board as we move forward in line with national priorities and direction of travel. Just around performance, so essentially my role up to yesterday, but still kind of carrying through to today, is essentially a chief operating officer for the system. So it's working across partners in the system to ensure that we maintain flow in terms of our operational position, particularly around planned care and urgent care, and also looking at meeting national performance targets that we are set through the planning process. In terms of this agenda, as Claire said, it's really tricky, isn't it? Because you've got to square a circle that says you've got a finite amount of money, we've got a population need, and then we need to meet a set of performance standards. And we know that performance standards, whilst very important, are only part of that picture in terms of the quality of care that our population receives. So we've got to ensure that we can look across all of these domains, as Claire says, live within our means, but also meet the standards that we need to and do the best that we can for our population and ensure that we're doing it with equity and fairness, really, as we work through. So Claire's referenced a couple of the performance standards there. I think particularly pertinent to today are the ones in relation to planned care, which has featured quite heavily in our efficiency programme. So clearly we've been on quite a journey since COVID in terms of recovering the backlogs of waiting lists, and we've been asked this year to ensure that less than 1% of our total waiting list are waiting in excess of 52 weeks. And we've also been set some targets around the percentage of people who get to first outpatient appointment within 18 weeks and our overall 18-week compliance, which was the traditional sort of referral to treatment target. Other targets that are here, but perhaps not fully pertinent to today, linked to emergency care, and I believe you had an update a few weeks ago now in terms of winter planning and what we're doing around those targets, particularly in terms of 4-hour standard and ambulance response times and ambulance handovers. And then there are other specific targets in play around mental health, primary care, quality and safety, and inequalities, which sit alongside the money as part of our planning ask for the year. So I'll just pass to Rachel in case you want to add anything.
Thank you. So, yes, I've had a slight change in my role. So I am Interim Chief Medical Officer across Staffordshire, Stoke and now Shropshire, Telford and Wrekin as well, as from today. I think I've spoken to you before around the plan and how this has been a real opportunity for clinicians to be and professionals to be part of this plan. We were very aware at the start of the ask that actually there was a lot of things that we were doing that were adding no value to patients at all, and we were not using the resources in the most effective way. We worked with our Health and Care Senate, which is the senior health and care leaders across the entire system, and really put it to them at the very beginning of this plan that things that we are doing that don't add value. We were really given a lot of things that people were doing at the front line that were not adding value to patients and not improving outcomes. So it was a real opportunity to work collaboratively with our finance colleagues and our clinical colleagues and people at the front line to say, what are the things that we're doing that are not adding value, and how can we change that and actually improve outcomes with the same resources? We were all very committed and knew that things were happening that we could really improve on. Quite an exciting opportunity for us as clinicians actually to really make some change and really impact the use of resources, and actually it benefits patients and it also benefits the staff working within the system as well. And we went into this knowing that we could be able to change those metrics around the outcomes. I'm really pleased to say that we have shown that to happen during this year. So you can see in the papers, I know I've talked about all nutritional supplements in the past. We've seen some really great work coming out of that with improvements in upskilling clinicians to get the right people to the dietitians. So the dietetic service, the waiting time has actually decreased because we've got the right people in there, and we're doing it with a reduction in the finances, improved outcomes, improved waiting times. So this is really possible, and we knew at the start of this that we could do this. So I'm really proud of this plan and the way we've worked with finance colleagues and clinicians and really built that relationship to really do embed a plan that benefits patients and uses the resources most effectively. And this was the bit that we really wanted to do as we moved into this plan. So in the paper, there's also some areas around prescribing and around primary care, some further schemes that we've done. But this is a process that's been very, very successful, and we intend to keep going with that. Actually, we need to use those resources in the most effective way around some of the way that we embed policy that make sure that we're actually using best practice, because best practice is often improves the outcomes and uses the resources most effectively. So for us as clinicians working with our finance colleagues, this is the beginning, and the results from this year have been really, really positive. So I'll hand back to Claire.
Thank you. Happy to take any questions.
Thank you. I actually would like to ask the first question on your report in section part 11, and it says here, which concerns me. It says the reduction in cancer weights. Now, obviously, it's government policy that diagnosis is expedited within at least 62 days, and then obviously faster diagnosis to be ruled out within 31 days. So if there's no treatment needed, to be ruled out in 31 days. Now, with cancer weights, obviously, because it's government policy, what I want to know is why is there a wait time then? And why is it that's happening, really? I mean, yeah.
Thank you for the question. If I respond on that one, if it's okay. So absolutely, cancer treatment works at the very highest priority level on our elective and planned care perspective. So those are national standards that were set to us, essentially say that within 28 days, 80% of people should have a diagnosis of cancer or not, so cancer ruled in or out, and then 75% should have a total pathway, so from being referred to starting their first definitive treatment within 62 days. So those are the national standards that we're asked to work to. Now, a couple of areas end up being more challenging than others in terms of some of the tumour sites. So earlier in the summer, certainly we were on track with delivery against all of those. That slipped a little bit as we got to September, October, and it's largely been driven by skin cancer referrals. So I think post the summer, we've seen quite a significant surge in demand in that space. But hopefully that just helps in terms of what those national standards are, and those are very much the ones that we work to delivering as a system.
Thank you. So you're working to deliver them. So what I wanted to, so why is it that they're not quite being delivered then? Because obviously in the report it's saying that you need to, if cost continues to be incurred, it diverts funding from high key and priority areas to reduce.
Sorry, yeah. So I think what that's essentially saying is we've got the financial envelope we need to work within, and if we continue doing low or no value work, then that would impact on the availability of resource to deliver the high priority, the longer waits and the cancer waits. Therefore, our absolute focus and commitment is around delivering those cancer waits. They sit at the highest priority, so we've not taken any resource away from those whatsoever in this. I think we're just talking about the fact that within that total pot of money that Claire talked about, we have to allocate and decide how we spend that, and cancer is the highest priority within that. Is that clear? Sorry.
Yeah, thank you. Councillor Brown.
Good morning. Thank you very much for that. Thank you, Chair. Yeah, I just want to go over this a little bit, if you don't mind. It's exactly what the Chair was saying was what I was thinking. I'm really, really concerned that we're going, for national statistics, so that's 62 days from diagnosis to treatments. That means that cancer patients in this part of Staffordshire and Stoke have got, obviously now it's going to go into Shropshire because we haven't even heard about Shropshire's figures and how they're going to affect us, and Telford and Wrekin. So that's 3 months that patients have to wait for treatment. We're hearing this is a national target, a national issue, but in Staffordshire, surely we should be looking at a far, far better treatment time than 62 days. And I'd also like to mention at this time also, diagnostic tests used to be a 2-week turnaround. So from when you first saw your GP to getting a diagnosis, not that long ago, that was the target. And it seems shocking that we're suddenly going into such a situation. So all our residents are going to have to wait longer than the 2-week wait now for diagnostics. Is that correct, firstly? And also, secondly, that even when they've got cancer, they've got to wait a whole and more than 2 months to get treatment. So breast cancer patients to get any chemotherapy, bowel cancer patients, bone cancer, it's absolutely shocking, isn't it? And I think everyone else must agree with it. And I think really we shouldn't be looking at the 62 days. In Staffordshire and Stoke-on-Trent, we should be looking at improving this. So thanks very much. And I have some other issues to bring up later, but thank you.
Yeah. All right, if I just respond to that, so thank you. So, sorry if I wasn't clear in terms of how I set out that target. So that is the national standard that from a referral, so from someone seeing their GP, through to having had their diagnostics, received a definitive diagnosis and starting their treatment within 62 days. That is the kind of maximum limit, if you like, that nationally they expect us to work within. So when you look at many of the tumour sites, they're far, far shorter than that, and certainly the work we do day in, day out is to bring those down as much as possible. But that is the national standard that we are measured against and that we're required to report against, but that does not mean that we make everybody wait 62 days. That means we get people's diagnosis and treatment started as soon as possible within that window, but that's just the metric that we're monitored against. Does that make sense? Sorry.
Yeah, no, that's great. Thank you. But I think we want to know the figures, please. Could we have the figures, you know, for last month, as it were? Could they, Chair, could we have the figures of what is going on with some of the cancer
Yeah,
rates?
yeah.
So that
I
we
mean,
understand it's not a national figure that we're necessary. You know, you've got to achieve that, but we really want to know what's happening in Staffordshire. So if we could have some figures, up-to-date figures, I think that would be really good, Chair.
Yeah, absolutely. So I'm happy to sort of separately provide a breakdown of those figures. So what we do is we monitor it by tumour site, so we can track through in terms of what the delivery is. Like I say, skin cancer is the one that's more challenging for us at the moment, with a real surge in demand after the summer, but the majority of other ones are at 62 or less than 62 days, but we can provide you with that breakdown. And like I say, we've got teams who are working day in, day out, actively tracking those patients at every step of that pathway to really chase that down. It is a top priority. Thanks.
Sorry, Chair, if I just make... Obviously, this information isn't going to be extra work, is it, to you? Because it's already there. You're already doing that, yeah?
Yeah, absolutely. We have it every single day. The teams are working through this, and we also have weekly conversations with NHS England to go through it as well, to provide a layer of assurance. But like I say, just to reaffirm that cancer delivery is absolutely top priority. Thank you.
Could I just come in on that from a clinical perspective? Because I didn't mention at the beginning, my GP that I work in New Toxeter. So the reality is that 62 days is the sort of outward target. So but if you think about how diagnosis works, and I know it's very different depending on where that tumour site is, but that might involve a number of diagnostics in those 62 days. It might involve a number of outpatient appointments. So it's very variable in terms of the tumour site trying to actually reach that diagnosis and actually treat that patient. So I think there's a lot of variability in that number, and I would sort of caution against that, just reviewing there's that 62 day. I absolutely take your point around it, but there is a lot of detail that sits in between time around diagnosis, and a lot of patients are actually treated well before that. So I think we need to, that is a standard that we look at and we measured at, and it's a national thing that's asked of us, but there's a lot of detail and very individual detail that sits between that. So I would just add some caution about seeing it as an absolute and the only thing to measure, because actually at the front line it looks very different to that.
And sorry, just to add, I suppose this is the whole point of our efficiency programme. So I think you said about, well, 62 days, why are we not going quicker? Why should we not go faster? Absolutely, 100%. And actually, here's the opportunity. If we ensure that we can reduce down our spend in areas that we know we shouldn't be spending, actually we can put further investment in terms of making sure that we can go faster and go quicker.
Thank you, Chair. Yeah, is there one area that's delaying everything? So, for instance, diagnostic tests, is there one particular area that is a problem that you're focusing on that might help? Thank you.
So in terms of the diagnostics, there's, again, a range of performance across. The one that has been a challenge for us, not just limited to cancer, is non-obstetric ultrasound in recent months. That was largely driven by increase in demand, some workforce challenges at UH&M. But what we've done there is implement a range of measures, including improving the workforce position, but we're also using the Cannock Community Diagnostics Centre to help us get that backlog under control in that space. And if I just steal one more moment around cancer, the best thing to do with cancer is the early detection, and I lead a range of campaigns that are launched. So recently we've just had Breast Cancer Awareness Month, and we've had prostate cancer as well, and there's a whole range of campaigns that work throughout the year, because the earliest possible diagnosis is the thing we want to get to. So we've got a whole range of measures in that space, including things like we had a cancer bus earlier in the year which went out to communities, particularly some of those harder to reach groups, and supported people, encouraging them to have tests and screening and things like that, because it's one of those situations where the very earliest you get it, the much better the long-term outcome is. So just to emphasise, we have that focus as well as tracking people who are on the pathway as well. Thank you.
I think this is another case where the clinical value is really, really important. So for diagnostics, it's making sure the right patient is referred for the right test as well. So there's some really great work that we're able to do around that area to make sure that the lists have people on it that need that particular test. So we're working with clinicians, with the Senate around making sure that the diagnostics are used in the most appropriate way. And it is a bit like when I talked about the getting the right people to the dietetics services. If we can do that around the diagnostics and really continue to work with that, that will mean that the waiting times will reduce if the right criteria is applied to those requests, and the right people will get those diagnostics, and it will support the cancer agenda as well. So again, I think the value agenda is really important in this area around supporting the best outcomes for patients by using those resources in the most appropriate way.
Okay, thank you. Councillor Edgeler.
Thank you very much, Chairman. Good morning, everyone, and thank you very much for your report. And my question actually relates to children. And where do we sit with children in this report? You know, and you talk about early intervention in cancer, which is great, you know, because it's what we need. But where do we sit with children with early intervention, please? You know, because if we can pick these children up that's got problems and that at an early stage, then I'm sure in the long term it will save a lot of money later on. So I just wonder in your plans where children sit within this. Thank you.
So they do absolutely front and centre sit within the plans. There's a lot of work ongoing in terms of ensuring that we can reach children at an early stage and ensure that their needs are met. Apologies that hasn't come out in the report. What we can do is provide supplementary information in terms of the areas that we're focusing on, particularly in this financial year, but also we're currently underway with our 26-27 planning over a 5-year period and 10-year period. And actually, we really have got a lot of work going on in terms of focusing on children and young people. So we can bring something back.
Thank you, Chairman. I would welcome that, and I think the committee would welcome that as well. So thank you. If you could give us that information, that would be great. Thank you.
Let's get any more follow-up questions? No, thank you. Okay. Councillor Wallins.
Thank you, Chairman. Good morning, everyone. On the topic of the £95 million deficit support funding that must be repaid, what is your risk plan if the NHS England withholds future instalments due to missed efficiency milestones? Thank you.
So thank you for the question. We are working on the assumption, given our year-to-date delivery, that we will receive the full 95 million in this financial year. We've received 3/4 of it to date. They will be basing the final quarter on our month 8 position. And given, I know we're only on working day 1, but given what we know at this point in the month and in the year, we're confident that we will be in receipt of the full 95 million at this point in time.
Thank you. I just have a couple of more questions to ask. Just to follow up on the previous question I asked, can you confirm whether any frontline services are exposed if the repayments become unmanageable after 27-28?
Sorry, could you just repeat that in terms of...
Yeah, that's fine. Can you confirm whether any frontline services are exposed if the repayments become unmanageable after 27-28?
Absolutely. So there's been some changes to the NHS financial framework, which has recently been published. So our expectations is that we will receive the 95 million in 26-27, which we previously had to repay on an annual basis. So the expectation would be that there'd be a deficit repayment of about 12 million in 26-27. However, given the performance that we're currently undertaking, we are confident that, as I said, we'll receive the 95 million. And what they're looking to do is pause the repayment on delivery of this financial year. And the new business rules state that if we continue to meet that requirement over the next 2 years, again, the deficit repayment would be paused. Recognising the question over if we didn't deliver the next 2 financial years, what that would look like and whether or not there'd be any impact on frontline services. Of course, we would have to protect all of our frontline services, and we continue to know that there's I think it's evident within the reports that there's areas of spend that we would be wanting to reduce. We continue to want to reduce. This is only the start of our financial improvement and efficiency programme. We know that there's still plenty of opportunity around productivity. Our workforce has grown since COVID, yet our productivity has remained still relatively low. So in answer to your question, no, we would not be having any impact on frontline services, because we would still want to make sure that we're focusing on reducing waste where we can.
Thank you. And just the one more question I got. Staffordshire has the highest prescribing spend per capita of any ICB. When will we reach the national average, and what accountability measures exist for practices constantly failing to comply with cost-effective prescribing policy? Thank you.
So I'll start by saying that is correct. We were the worst prescribing in terms of spend. However, I'm pleased to say that since the work has been undertaken as per this efficiency programme, whilst it's still some way to go, we're now at 4th. The latest information has come through, and we believe if we continue to carry out this programme of work, actually we will start to come more in line with the national averages. Rachel probably wants to add some more context to that.
Yeah, so you see in the pack some of the things that we've done around prescribing. This was clearly a great opportunity to really improve that use of that money and make sure that we were doing all we could. If you look at the programmes as well, the way we've done it is around using more cost-effective prescribing. We've talked about the oral nutritional supplements. I mean, we were massive outliers nationally on that, and we have come right down into the pack around how we use that resource, working with our experts on the front line to do that. In terms of how we work with practices, obviously the spend is a system spend around the interface with prescribing is across primary, secondary care, and that's why when we do these projects, we make sure we work across all of the system to improve that, because one area of spend, say in secondary care, and this is just sort of pulling the example, can impact on how prescribing is impacted in primary care. So it's really important that we work full across the system. And the project that we did that was successful, we worked across the whole system to make sure the policy was implemented. We work with our practices very closely around some of the prescribing. That's what we've done for a long time, but we've really pushed on that. I think the key difference and the reason why we've really improved on this is that we've worked across system. So we've worked with all partners, because one part of the system does not sit in isolation. We will continue to do this. We've talked about biosimilars, so meds. There's a very sort of dynamic way that prescribing happens, in that things come off patent. We can work with new drugs that come in that have the same effect but cost less. So this is a really active process that we do to make sure we're using that resource as effectively as possible. And we, again, as Claire has described, we have seen really good results this year in using that resource as effectively as we can. And what's been really good about this is that we will absolutely continue to be very proactive around this area, because clearly it's a large resource that we need to use effectively to get the best outcomes for patients. But it's something that we have to keep on top of every year.
Thank you.
Thank you for your questions, Councillor Wallins. Councillor Greatorex.
Thank you, Chairman. I'm not sure if you've seen the report, but we've got a covering report ahead of the one that goes into your details. I just want to read some of the detail. It's been put together by our officers, but you'll see why I want to ask the question. Says Staffordshire and Stoke ICB has been an outlier for continuing healthcare activity since 2022. And that's on our page 13. It goes on to page 14. The ICB has worked closely with system partners, including both Staffordshire and Stoke local authorities, the last 18 months to review and improve CHC processes. And goes on to say what they're going to achieve to set a 51 million efficiency target. I'd be interested to know what's been the discussion over the last 18 months to give some live examples of what's gone into that 51 million. So presumably there are things that have been discussed in the last 18 months with the two authorities, which you can quote, which are part of the budget now for this 51 million figure.
Hi, my name's Claire Underwood. I'm Director of Nursing for All Age Continuing Care in Staffordshire and Stoke-on-Trent ICB. So thank you for that question. So I've clinically led that programme of work, and I'm really proud to note that from a lot of the efficiency work that has been achieved, it's resulted in improvement, well, all of the efficiency work, improvements in outcomes and experience for individuals. We're a massive outlier for over-restrictive care, so individuals who are being supported with one-to-one care inappropriately. And also then, as a consequence, our eligibility rates from continuing healthcare. So just to give a few headlines, so Staffordshire, we have seen a slight reduction in eligibility for CHC. So compared to April 25, our eligibility was 582 Staffordshire residents. It is now 509 in October. But for funded nursing care, we've seen an increase from 1,294 in April to 1,363, which is what you would expect to see because we were a massive outlier for eligibility for CHC. We were the worst nationally and the worst regionally, which then had consequence on our spend. And a lot of that was in relation to over-restrictive care. We've worked, as you've said, with both local authorities on the programmes of work. So we've developed a joint operational protocol with that has been signed off at both joint commissioning boards with both Staffordshire and Stoke-on-Trent local authorities, and at all of our eligibility decision-making process. So from when the point of assessment or checklist for somebody, the councils and social workers are alongside that journey. And then when it to the point of eligibility decision, we have panels or meetings that a senior leader from the social workers, so from the local authority representing the county council, are there as part of our decision making to assure ourselves that this person's either eligible for continuing healthcare or funded nursing care, and we're getting the decisions right. And equally, that also leads us to moving people on to lesser restrictive care. And we've got many patient stories. We've got individuals where, and we talk about these every week, we've developed a system quality and governance group that's actually happening now, that's supported by both local authorities, many system partners, UH&M, Health Watch, mine's just gone blank. There's lots of system individuals. The CQC are part of that. We regularly meet with the CQC as well about all of the work that we've been doing. So I'm not sure if that answers your question fully. We're also working on joint funded individuals with the local authority. We are just about to, we've got in draft an integrated support protocol, which we're working with Staffordshire County Council to sign off around how we will also apply the same principles that we've applied for continuing healthcare and funded nursing care around lesser restrictive care for individuals, which will then look to support a reduction in our joint funded approach. So that's around the elements that we call non-CHC, and that also applies to Section 117. So we've developed joint joint PIDs, and then equally QIAs that we're doing together with the council, because the joint programmes of work, which will equally see efficiency opportunity for both local authorities as well, and not just health. So from an improvement to experience and outcome, which that's what has driven all of this work.
Chairman, if I can come back, it doesn't really answer the question at all, does it? Because I asked for some examples of what has gone into those figures to justify that 51 million can be put in the budget. What you've described is how the figures have improved. You've described how there's been quality and governance groups. You've described how there's been joint funding projects. But from a point of view of scrutiny, we can't see what that has represented for the patient. We can't see how those costs have been reduced and what they've experienced that's been different. That was really what I was driving at. There is another part of the presentation which I'll probably go on to, which will help. It's page 19 of your PowerPoint presentation. It's page 35 in our numbering on the PDF. And that refers to SSOT being the highest CHC cost in the country population, which obviously you've said is no longer the case. As an outlier in one-to-one care, it needs alternative strategies. So first question was about the past tense, what's gone into the budget. Next question is, there are still some strategies required. Again, what can you demonstrate that you're looking at in terms of what might happen for our patients in Stoke and Staffordshire? And how does this become consistency with elsewhere? Avoiding things like a postcode lottery.
So I'll try and answer the question. So back to the first part that you didn't feel that I'd properly answered. So areas where that has reduced the spend, so this has been very much based on reduced spend and avoided then spend. It is around lesser restrictive care. So what that has meant is we haven't got individuals that are being cared for on a one-to-one basis unnecessarily that then distresses them further, leads to increasingly concerning behaviours for individuals, aggression, which is all unnecessary, and then over-prescription for medication for individuals. So it's it's cyclical really. So that's one of the most significant areas, which has then meant individuals are more independent, which improves their experience and outcome, and as a consequence, they're no longer eligible for CHC. CHC is a national framework that's there from guidance perspective, and the application of that then shouldn't lead to a postcode lottery, because if we have fair and equitable application of that framework, that we assure ourselves with social care colleagues that we are applying in a principle manner that's fair and equitable across the population. It's not just, it's a statutory duty of the ICB, but we do it collectively with both local authorities in the spirit of, in the best interest of the population and the best use of taxpayers' money. Going forward, those principles will continue to apply, and we'll apply where we've worked on it already into other areas, as I've described, such as Section 117, and where we've got joint funded, and looking at how we joint fund individuals who perhaps slip through the net where they're not CHC. It's more than what would be expected for a local authority to provide, but it's a health task as such. So that is another strategy that as we move forward into next year that we're looking at. Does that answer? I have got stories that I can share, particular case studies that I haven't got them all with me to hand, but I'll happily provide some.
Okay, thank you. Thank you for your question, Councillor. Councillor Kelly.
Thank you. So, on table 3, it says planned care / urgent and emergency care. However, throughout the report, I can only see references to planned care. So is it that is the only, that planned care is what's going to be affected, not urgent or emergency?
Do you want to take that? Yeah, so within the ICB plan, yes, it's predominantly, if 100% relates to planned care, where we would seek to find opportunities around urgent and emergency care. They will be sitting, the financial benefits of that would sit within provider plans.
Thank you. Sorry, I just want to clear that up before I went on to my next questions. Is that okay, Chair? So, it says your restricted procedure policy is going to change. So what sort of procedures are you looking to get rid of, and how many people will be affected?
Yeah, okay, so if I start that response, and then Rachel will pick up about the specific procedures. So yeah, so we're, in terms of our planned care monies that we're looking to save, we're looking at both excluded procedures, and Rachel will be able to give the list in terms of things that are not sort of clinically recommended to be carried out, restricted procedures, which are where they're essentially considered clinically on a case-by-case basis against criteria to say should this or should this not take place. But I don't know, Rachel, if you're okay just to give us a few examples of.
Yeah, so we do have a full policy on this, and it might be useful for us. I mean, it is on our website around the excluded and restricted procedures. There's quite a lot of detail in that, and they would go through. So it's structured in a way, so things like ENT, gynae, and the things that we do through that. They are evidence-based. Most systems will have an excluded and restricted procedures. We review it regularly, and we look at new evidence that comes through around procedures. So examples of excluded would be sort of some of the cosmetic procedures that we would have in there. We have restrictions around some of the criteria, which we've got quite detailed criteria about eligibility for things like some of the orthopaedic procedures, again around the way that it's structured. So it would be helpful, I think, for the committee to have our policy. As I said, we review it all the time around it, and the restricted procedures do have, it certainly comes through my directorate around how we make sure that we, the clinical questions that come, that we assess it against the criteria, so all patients are assessed. It's an equitable assessment around those criteria. So that's an ongoing process. We do also have individual funding requests if there's exceptional circumstances around some areas. We again have panels and procedures in place to deal with that as well. So it's quite a large area with a number of evidence-based policies that are attached to that. There is some national directive around it as well, and most, like as I said, most systems will have a excluded and restricted procedures or something named in that way around the use of those resources. So I think it would be helpful for us to give that policy to the committee.
And just to add to that, I mean, clearly we would all recognise that we've got theatre capacity constraints, and actually it's more appropriate to make sure that we're using our theatre capacity for the right procedures that we know that are clinical and evidence-based, rather than those procedures that actually there's national guidance and criteria which says we should not actually be carrying these procedures out.
So again, how many people will that affect, roughly?
I haven't got the figure, the number of people here to hand, but we can ensure that that's circulated.
Thank you. Councillor Doherty.
Yes, so my question is around the mental health, section 117. I have been looking at recent ombudsman complaints, all of which contain that there are repeated failures in discharge planning, poor record keeping, information not being provided to families correctly. So with all these failures that lead to patients feeling like they're being stuck in a revolving door, what measures going forward are in place to improve those things?
Thank you. And in response to that, we have recently, I think it's in about 2 months now it's been running, we've developed a joint panel called Joint Assurance Meeting. Well, it's a meeting, not a panel, with local authority colleagues, so from Staffordshire County Council, and we from a discharge perspective, so not just discharge, but anybody who's in the community who requires a change to their package or a discharge, to be assured, are we acting in the best interest of this individual? Is it the least restrictive care? Are we going to get the best experience and outcome? Is it does it meet their needs? So there's a discussion that's an MDT discussion, so it's clinical and from a professional side, from a social care perspective, and we examine each case that comes through in response to your note that you've described, really, to support improvement, to experience prevention of further, somebody going back into hospital, and also to support a successful discharge. So that's now been up and running about 8 weeks, it might be slightly more. So it is in its infancy, it is new, and that happens every week. And we also hear any urgent discharges out of hospital, they're heard and discussed outside of the meeting as well, in response to support the improvement to that area.
Just to also, and it's shown within the papers, clearly the ICB have made the commitment for the mental health investment standard, and that's demonstrated within the papers.
Can I just come in on that question? Because I actually have some questions of my own about 117. Obviously, we know that Section 3 patients will go through to 117 care eventually. So it says here that you want to cut 2 million from 2 schemes. So what is it that's actually being taken from those schemes? How is it going to affect patients that are going into 117 care? And how are we going to adequately provide for those that are going from Section 3 through to 117 to be able to provide them? As I know that obviously with what Councillor Doherty's just said, that they are being discharged early. I mean, how do we ensure that we're not doing that and we are ensuring that they are still receiving the care that they need?
Okay. So some of that is in reference to what I just spoke about. So it's around the lesser restrictive care. Again, we've got evidence of individuals that are being over-restricted in their care. So they're over-prescribed care or one-to-one care that's unnecessary at times. So we've got evidence where, and again, we've worked on this with the local authority, where we can see, and again, stories where we can share stories where we've already improved.
Okay, I'm not talking about the ones that are being over-restricted. I'm talking about the people that are being discharged that still need that care.
So it's the same cohort of people. So some of those will be being discharged with one-to-ones. So it's about stepping those down or working on a reduction for those to promote independence for people. So it's about rehabilitating and promoting the independence of individuals as much as possible, despite the fact that they're Section 117 funded, so that, again, from an experience and outcome perspective, it's the best that they can be, and also to prevent further hospitalisation, which then comes alongside that, is increased funding and that risk aversion, really. So it is very much about how do we work with supported living, the third sector, in a very different way to support such individuals for the future, but in a collective and collaborative way with system partners. So it meets the needs, it's specific to the needs of the individual, and it's based on that assessment.
Right, okay. So, okay, Tracy. I'll let Tracy come in on this.
So, as you probably know, I am a mental health nurse by background. So the Section 3 obviously is an assessment, it's a treatment section for people, and people who really, need quite a lot of support. So the planning for their discharge is part of that Section 117, which I think ties into what Claire is saying. So what we found is people have a lot of need when they come out of hospital, and that's understandable. But what perhaps we haven't been as good at is reviewing that, because what we're trying to do is to prevent people coming back into hospital. That's the main thing with the Section 117 treatment, whatever plan we put in place. But what we need to do is keep reviewing that, because we need to do the best for the individuals, and they might not need all what they're getting, and actually can live a lot more free life. So that's the importance of having those reviews going right the way through. And then be really quick, because if somebody's becoming unwell, or we know what their care plan is and we can see their triggers, that actually we can get in and put something in place that may not necessarily mean an admission. It'll prevent that admission and be better for the individual to remain in the community. So it's a whole cyclical thing, and I think that's what Claire's probably alluding to. I hope that helps.
And how can we assure that we're not putting people into care in the community that still need higher levels of care? Like, that is my question, because there are cases of people that need the higher levels of care and they're being pushed through. They're being...
Tracy, go on that one.
There's an end one over there.
Want to sit on the
So there are people that...
Okay. Yeah, so thank you. And I
that
think
need the higher levels of care that are not being given that, and they're being pushed through to care in the community and to have more freedom, but they actually do still need the higher levels of care. And I understand where you're coming from, and I understand it's a more humane way of dealing with certain patients. However, they still need that care, and I've seen that it seems to be easier to push them through to less costly measures to care in the community rather than still giving them the full type of care that they need. And I just want to make sure that we are not putting people through, pushing them quickly through 117 if they've come in on a Section 3 and other sections, and they're being pushed through to lower levels of care when they actually still need the higher levels.
So without going into the details of the Mental Health Act and the necessity that is required to remove somebody from a Section 3 in order to put a Section 117, that's quite detailed. So there's lots of legal parameters around that planning for care. So you've got a lot of clinicians involved within that planning for care, and they have to go through, it's quite a legal process because the Mental Health Act obviously is a legal thing. So for me, I would be more assured that going through the Section 3 and the 117 that people do get the care that they need going out, because literally else all you do is they'd bounce back straight in again. But the amount of clinicians that are involved because of the way the Mental Health Act is, I'd be really assured, having been there and sat on many of Section 117 planning myself, I'd be more assured that would be, wouldn't be the case that they're going out on too lesser restrictive. They're going out on what they need to prevent them coming back into hospital, which is the important thing around it.
Can I just add one thing to that? So the joint meeting that we've set up with the local authority, it isn't just about assuring ourselves, is it the least restrictive care, is it the right care? So it will also push back if we think it's not meeting the person's needs as well. If there's not the evidence and the assurance that it's going to protect them and protect the public potentially, then we won't, it will be pushed back. And even if that then is appeared as a delayed discharge, there will be pushback. If it's not right and it's not right for that person, it will be pushed back. And that then within the system leads to a bit of noise to be saying you're delaying a discharge. Well, no, we're not. We're getting the discharge safe and right. So that also is a priority for that discussion.
Okay, thank you. I think Councillor Edgeler wanted to come in on this as well.
I did, thank you. Yes, we all know that mental health is a growing concern throughout the country, but we've not mentioned anything about Midland Partnership Foundation Trust in this, and what I'm thinking is there must be more information now. The ICB are working with the Midland Partnership Foundation Trust regarding mental health, and is there any more information that you can give to this committee to help us understand a little bit better about how we're moving forward with mental health issues? Thank you, Chairman.
I think this is an area that we should commit to doing a dedicated session in terms of mental health. More than happy for me to speak on behalf of my executive colleagues, given I am, and commit them to do that. Yeah. Okay.
Yeah, Chair, I would say mental health, that is a massive topic, absolutely broad, of all age mental health care, all the different types of mental health issues, and Midlands Partnership Trust would be probably better, and North Staff's Combined Healthcare as well, given your geography, would probably be better, that you may want to look at, mental health in its entirety rather than trying to cover it just here in this meeting.
And can I just assure, though, that those discussions, that meeting, MPFT are part of that meeting as well, so that the clinical discussion around Section 117 assurance, they are also there.
Can I just have a show of hands in who would like to bring that to committee if you wanted to bring it as a separate issue? Okay, thanks. Councillor Edgeler, sorry?
Just to say thank you for that, and I look forward to us having a meeting on mental health. Thank you, Chair.
Okay, thank you. I think Councillor Brown wanted to come in.
Yeah, apologies, but I do have a few questions which I will break up if that's all right, Chair. Firstly, I'd like to see for you to respond to the relevance for East Staffordshire, and I suspect this also includes Lichfield and Tamworth, because university hospitals of Derby and Burton are not mentioned in any of this today, which really is quite concerning when the ICB is covering it all. And also, what the relevance of now bringing in Shropshire and Telford and Wrekin, how is that going to affect people in Staffordshire, Stoke-on-Trent, and of course the East Staffordshire County of the East Staffordshire Borough East Council, which is part of my patch. Thank you, and then I'll come back with others.
Yeah, okay, thank you. So the ICB has responsibility for the population health. So as you rightly say, I think depending which area you look at, between 50 and 60% of the population flows into University Hospital North Midlands, and then the rest out and across UHDB and RWT being the two key ones there. So so when we're looking at applying, for example, going back to restricted procedure policies, we are looking at those across the piece as well with all of our providers who provide service for us. The other bit, just in terms of the new cluster arrangement with Shropshire, Telford and Wrekin, which is now in place, we retain two separate legal identities as two separate organisations for the moment, pending any future merger conversations. So although we're now moving to a joint leadership structure, our reporting and accountabilities still sit very much across the two geographies.
Chair, just as supplementary to this, just a point, obviously you've not really answered my question about the east of the county. I think moving forward we really need to see those figures, what's going on, because at the moment we're blind and we haven't a clue what's going on for Burton, which is a really important part, and Samuel Johnson and Sir Robert Peel.
I was so just to, in terms of the paper that's been put forward, and I alluded to it earlier in terms of the changes to the NHS framework from 26-27. So previously, for 25-26 and for prior years, we have had to describe our financial positions on a system basis, and within our system it includes the Integrated Care Board, it includes University Hospitals North Midlands, it includes Midlands Partnership Trust and also North Staffs combined. That is not to say that we don't work very closely and have the information for Derby and Burton and also Royal Wolverhampton and other organisations, but from a performance perspective we've been monitored basically on that system footprint. Moving forward, there will be more of a focus on individual organisation accountability, but certainly we can ensure that the performance information for those organisations is picked up as part of future reports. That's not a problem.
Just to come in from a clinical perspective, so and personally, I'm a GP in New Toxteth, and I've worked in East Staffordshire for over 20 years, without being too specific about how much over 20 years that is. And I was previously chair of East Staffs CCG, so I'm very aware of UHDB particularly. But when we come to work clinically, we work across the entire patch. So I know there's some nuances around, where Burton sits with its sort of, the sort of relationship with Derbyshire. We're very aware of that, work with our Derbyshire colleagues. I meet regularly with the medical director in Burton and work across, obviously there's the into RWT and UHB. So very aware in the south of the county that we work really closely with them. So when we were doing, to go back to the excluded and restricted procedures, we worked really closely with our Derbyshire colleagues, and we always continue to do that. They're part of our meetings. And so from a clinical perspective, I just want to assure you that we do work really closely with them, and we're very aware of our patient flows. And when we go into the neighbourhood agenda, that's going to be absolutely front and centre of the next few years, working in those neighbourhoods that are really important and around the patient flows will be, the highest of priorities. But because of where I've come from and where I still work, in general practice, I'm very, very aware of the patient flows, and it's really important that we make sure that the work that we do is focused on the entire geography, and that's certainly from a clinical perspective, that's what we do.
And just if I can really briefly add, so I think as colleagues have said, there's different lenses through which the data is looked at through a planning process, but certainly when we come to report to the ICB Public Board, for example, on waiting lists, we look at the waiting lists and the profile of that waiting list for all of the population, irrespective of where their treatment is taking place. So that information is very much seen and scrutinised by our committees and boards as well.
Thank you, Chair. Well, it's just a case of we have no figures. You've brought nothing to us for... obviously, I'm sure your word is... I respect your word very much, don't get me wrong. But today, we've got no figures that reflect any of for East Staffordshire or Tamworth or Lichfield. So just moving forward, I think we, to the committee, want to see these things, don't they, I presume? Because we're all representing people from the whole of Staffordshire. Thank you very much. Sorry, if I put my mic on would help, wouldn't it? At the last meeting, we had winter planning for West Midlands Ambulance Service. And obviously the big white elephant that I raised was the waiting times, which you said in 25-26 A&E, a high proportion of patients will leave A&E within 12 hours compared with previous years. 78% of patients leaving A&E within 4 hours. Average handover times for ambulances, 30 minutes. Well, as you're probably aware, 41,000 hours were lost for the whole of the West Midlands in October. The committee last month obviously debated this greatly. I said it was the white elephant because it's just a huge, huge part of what's going on. The waste of time, the waste of hours, the waste of money. And I think it's absolutely paramount that we want to see meaningful action on this. And we didn't, obviously, it wasn't West Midlands Ambulance's position to tell us what is going on. They say they're working cross with everybody, but this is a huge, huge part and a huge waste of resources and money and efficiency. And I think the whole committee here really want to know, how are you going to achieve these? We don't want to just hear about steering groups and working parties. We want to really know what is happening, and we really need, obviously, a dynamic approach or something to this. So I'd like to hear about that. And the second point is the lack of GP appointments leading to a huge attendance also in the emergency department? And I don't really want to hear, oh, it's the back door, it's what's happening in the hospital. I think there's more to this, and I think the front of door white elephant and the lack of GP appointments is one part of it, but I really like to hear what's going on. And that really concludes, thank you, what I've got to say. Thank you very much.
Okay, thank you. If I start off with there, Rachel may want to come in a bit around primary care as well. So absolutely, I think the report you received last time, I wasn't present for that, but went through all of the measures being put in place for the winter period. We've had what I would say a combination of focus around capacity and a focus around process as well, because this isn't just about building extra beds here, having more ambulances here or whatever. This is about the ways people are working, the way that organisations are working, the way that the whole system's locking together. So there's been national support, for example, into UH&M since January last year, which is supporting in terms of the internal process bit within the acute hospital. And indeed, we did see some significant reductions in terms of the ambulance hours outside of hospital as we headed through the summer. That has, again, become very challenging as we've headed into the autumn. A few kind of drivers around that. I mean, certainly, and this isn't an excuse, this is just what the national situation is. We've seen very early onset of respiratory illness this year compared to previous years. So UK HSA is saying we're about 4 weeks ahead of the curve that they expected to see. So, for example, we've gone from 40 flu-in patients on Friday to 70 today, and that is ramping up. So clearly we're seeing problems with acuity there. But fundamentally, the challenge of ambulance handover delays is a whole system one. It's something that we've got to address all across the pathway. So it's about the appropriateness of conveyance in the first place, and that links right the way back to general practice to 111 in terms of what's being passed through to the ambulance service. We then have a single point of access for those care professionals to contact, where they can seek advice and seek to understand if the acute hospital is the best path for the patient to go down. So that's where we work with our ambulance service colleagues to try and promote them contacting and using that service, because, for example, it might be that a falls response service can go out to someone's home and see them rather than them being conveyed to hospital. So all of this seeks to ensure that only those who absolutely have an acute need are presenting at hospital. And then we've got the conveyance itself, and as you've rightly said, we've had a real deterioration in terms of our ambulance handover times, which then has an impact in terms of ambulance response times to the patients. So it's that process work within the acute hospital, opening additional capacity as we head into winter to ensure that we've got the capacity to treat those patients, and then ensuring that flow through hospital and flow out is being managed. So it really is a whole system challenge, but certainly it's my sort of number one concern at the moment. I know if Simon Constable, the Chief Exec of UHNM, was here, he'd say it's very much at the top of his list, and it's something that senior colleagues across the system meet and discuss several times a day in terms of what are the actions and what are we doing to improve flow. A number of capacity schemes, as I say, are online, and a number are coming online. And one of those schemes is in general practice. We've had success with winter hubs before, winter respiratory hubs. So that's additional GP appointments, which we're ramping up over the last couple of weeks, and I think will pretty much be fully in place now, Rachel, and there are many tens of thousands of appointments. I can't think of the figure offhand. Is there anything you want to add from primary care?
So, yeah, I mean, GP access is always really, really important for us to focus on. There's been about a 20% increase in appointments since COVID in general practice. Real increase in productivity in there. Having said that, you know, general practice sees over 90% of the activity in the NHS, and it's something that we need to continually work at. You are probably aware that two really important things is the additional roles that are in general practice now. So appointments, and you've done a lot of work with communities around this, that appointments are not always with a GP, and other appointments are offered around the additional roles that have been in place for a number of years now, and we obviously work with practices around that. Just recently, there's been a change around the online access. You're probably aware that you can contact your GP online for the non-urgent, and it's open sort of from 8 till 6:30. So GPs then look at those and then are able to put them into the most appropriate professional or the appointment as required. So that's been some change as well. Obviously, we've got 142 practices in Staffordshire and Stoke-on-Trent, and so it's really important for us to make sure we have consistency across access as well. So we have a quality dashboard, and we work with our practices, and we're able to support practices that need additional support around the access. So we have lots of metrics that we measure to make sure that that variability is limited, and we have consistency across the patch. And obviously, as we work with Shropshire as well, we will maintain that consistency and that quality and that focus on quality across general practice. There is a huge demand, and sometimes as you know, with an ageing population, the complexity and the acuity is increasing. So we need to support practices, and there's lots of things we do working around frailty with practices to ensure that we care for patients in the community as most effectively as possible. I've talked already about neighbourhoods, so as we go into the neighbourhoods, neighbourhood agenda in the 10-year plan, general practice will be front and centre of that, and the work with integrated community teams to support people at home as well. But the access, there are so many elements to making sure that we maintain as maximum access to general practice as we can, and making sure the patients get to the right professional at the right time. But having said that, it remains a challenge, and lots of things change. But there's lots of work that we do, and we will continue to do, to ensure that patients are treated as much as possible in the community, and we want to avoid them deteriorating to the point where they need ambulances, and then we talk about the consequences of that. So we continue to work around the access with general practice.
And sorry, just to add, because I found the number, it's 46,000 additional GP appointments across winter, but predominantly over December and January, to support better access. Thank you. And those are across the whole geography.
I'd just like to say that we do have the GPs coming in January. So if we've got any more questions about GPs, then we can actually we've got a meeting specifically for that.
Thank you, Chair. Thank you, Chair. Just to say, thank you for that, and I acknowledge that bit. I'm concerned, and we'll talk about it another time, that you mentioned really important, the GP appointments and the additional roles, but there's nothing like having a GP appointment. And I do believe there's a postcode lottery at the moment with GP access, and 41,000 sounds like an amazing, but we seem to be on a reactive rather than a proactive approach. So I still have concerns, but we'll discuss this in more. But thank you very much, and thanks for your response.
Thank you. We've got another meeting in January for GPs, so if you'd like to answer, I'll... Yeah,
I think it would be... I mean, obviously we all have our own GPs, and and we all have our own experience, which might sort of determine how we feel about the access. The Ours Rolls is a national scheme. And we've rolled it out, to that national directive, and there's lots of really positive things that happen with the additional roles and patient experiences with that. I also think it would be helpful to understand the GP access numbers as well, to just inform you of how they have increased and what that means. The general practice has changed, so actually there's still lots of GP appointments, but I think it's important to say that we've done lots of work with our communities around how going into a GP, you might not always see a GP, but we would want to make sure that the patients are directed to the most appropriate professional. We've worked really closely with practices to make sure that happens. So if you need a GP, you still see a GP.
Okay, thank you for answering. Thank you for your question. Councillor Norman.
Thank you, Chair. I put my hand up quite some time ago, but so going back a little bit here, so I apologise for that. But on the deficit, the question I was asked about the deficit was just perfectly okay. Only trouble is that when we were at Lichfield District, the leader of this council then did not like any questions on the deficit, which is a bit weird in my opinion. But my question only to you is, on this particular aspect, is how long have you had a deficit, and your predecessors, how long have you had a deficit of some sort?
So you'll be aware that I think I came into post on the 1st of July as interim. No. And for as long as I remember, this system has been in a financially challenged position, which had some respite during the COVID duration. As you know, there was significant amount of financial resources that was put into the NHS, which alleviated some of the challenges within Staffordshire and Stoke-on-Trent. So the system has been in financial distress for a fair period of time. The NHS is moving back to a world where deficits are no longer seen as acceptable, nor should they be. We have a statutory duty to break even, and where we need to focus our attention now is how we're going to recover the 95 million over the medium term, which will be the focus of the planning submission, which will be we are required to submit our final planning submission for 26-27 in February 26.
Thank you, Chair. It was only to give context to the deficit question. and I'm glad to see that it won't be there for forever. Next point was about cancer action. If I quote from Lord Darcy's, or summary of Lord Darcy's letter to the Secretary of State in November last year, when he says the National Health Service is in serious trouble, he mentions that the 62-day target for referral to first treatment has not been met since 2015, and in May 2024, performance was just 65.8%. More than 30% of patients are waiting longer than 31 days for radical radiotherapy. My only question on this really is about where best practice is. I mean, for scrutiny, it's always useful to look at other local authorities, see what they're doing, where the best practice is, and try and introduce it. It's much more difficult with ICBs, I think, to find on websites the same sort of reports that we have here in Scrutiny. But I just wonder if you knew where there was a best practice place, ICB or whatever. I might be able to follow that up and have a look at that. That's all. Thank you.
Yeah, well, certainly, and following on from the discussions around the cancer targets and performance earlier on, I've put myself a note because I think it'd be really helpful to do at least a briefing note for you around where we are, where some of those challenges are, but certainly get some of our lead cancer clinicians perhaps along to a future meeting, because we're very well networked across the country and different areas, different tumour sites. There are different things that are being sort of piloted and used, and I know there's a number of innovative schemes underway in terms of cancer treatment that we are working from. So I think it'd be helpful if I can just bring all that together into one package for you, if that's okay, and just provide that through to you.
Again, thank you. Obviously, what I want to know is, are you able to follow the best practice in those cases, and then what are the impediments? But that's for future. So I'm that's all I'm asking for in the script.
Yeah, and certainly there are best practice guidelines for each pathway, which we will be adhering to. But then it's about some of the more innovative approaches to treatment that I think it would be helpful to hear about here in future.
So my last question then is leads on to that, which is about the analog to digital. If I have a doctor's appointment or the GP practice, which I have no problems with, by the way, I don't get a letter, I get a text, and then I'll get 2 or 3 texts before that. So it's impossible, in theory, for me to miss an appointment. If I have an hospital appointment, it's a different world. It's a letter. Well, there's no follow-up text or reminder. In fact, in one case, I had one letter, then another letter with a different date on it, month and a later date. So I thought, oh, now then, is this to replace the one because there's a delay? Okay, fair enough. So I have to ring up to find out, and the person I'm speaking to on the number on the letter says, well, no, I don't know, you'll have to ring them. So you give this. And in other cases, just in my small circle of illness, as it were, around me, they say, well, the trust will talk to each other within the trust. So I'm talking about hospital problems with old-fashioned letters, which eventually get to you, and no follow-up there, so people can miss appointments. And then one letter the hospital not talking to the GP practice. So in a case where there's been a year's delay because information wasn't sent to them. I mean, I've heard it so often in this small situation that I'm in, that hopefully the digital aspects of and IT aspects of, I did my prescriptions this morning online, for example, will be improved. There's nothing in your reports that gives any examples of that, but only the need to do that. But if you've got any examples for future, that would be helpful. But I mean, it is mad that you get letters, and thank you, Chair.
So wholeheartedly agree, as not just within this system, but across the NHS, we're really not using digital technology, basic digital technology, well enough. So clearly, University Hospitals North Midlands would be better placed to respond back on some of those challenges around the letters. However, I'm very aware we are working closely with University Hospitals North Midlands in terms of access to additional capital investment to support the digital agenda. So it hasn't been announced yet in terms of the digital investment that is going to be made available for this particular patch. We're expecting it imminently, but what we will be doing is working with the trust in ensuring it accesses that, so we can start to ensure that there are the improvements in the basic digital technology that we should all just be used to. Sorry.
That information on Twitter.
link. That's absolutely, yes. I've said it, so.
Yeah, and just to add, I mean, obviously analog to digital is one of the big 3 shifts within the 10-year plan. So as we're looking ahead, there is absolutely huge opportunity in this space, isn't there, for us? But it absolutely has to be front and centre of what we're doing. Thank you.
Thank you, Councillor Norman. Councillor Hood.
Thank you, Chairman. You'll be relieved to know that most of what I'm going to talk about has already been talked about, so this is quite reduced. All-age continuing healthcare improvements. At the bottom of the page, it says market management. The ICB's programme centres around implementing robust systems and structures to ensure value for money of every care package commissioned. We all know that the ageing population is growing at an alarming rate because people are living longer. What concerns me, and I see this on a weekly basis, is an elderly person who has been termed by the media as a bed blocker. But what that actually equates to is that that elderly person, no one's found a care package suitable for them. Sometimes it means that they're moved miles and miles away, and this committee has discussed on a regular basis how traumatising that is for the family and probably for the individual as well. And the myth about, we are going to discuss mental health, but I have to say this, the myth about people on the section 117 having continuing care, I know that the homeless and rough sleepers, the majority of them will have gone through a section 117, but we have nowhere to actually send them because there's waiting queues. And to think that I've sort of got the impression through this paper that we're pushing people onto the community. You mentioned the community a number of times. We don't have the volunteers anymore. And you only have to be at an elderly person's house who is receiving a district nurse care, and the speed with which that nurse rattles through what she's doing, the service she's providing, is almost inhuman. I'm not saying that they're unkind to that person, but that nurse knows that they've got to go at tear speed to go on to their next patient. We haven't mentioned bed blocking. We've got lots of people who are in beds that shouldn't be there. And I just wonder how we see the way forward and the cuts that have, efficiency that have been identified just seem absolutely ludicrously high. Thank you, Chairman.
I'll start in response to some of those points, and then I'm sure that colleagues may want to come in. In terms of the way that we're describing the market management, so 100% we need to make sure that we've got sufficient suppliers ultimately within the market so that we can ensure that the patients that need continuing healthcare are accessing continuing healthcare. So when we're describing market management, it's that approach that we're looking at. We're also ensuring that we've got fair and equitable rates that we are paying to suppliers so that actually they're able to provide sufficient services so that they're not rushing in terms of some of the care that they're providing to our patients, our most vulnerable patients. So the other area, you were absolutely right in terms of we know that we have got patients that are within our acute setting at the moment that actually need to be placed elsewhere, not within that setting. There is a large piece of work going on at the moment to understand what the capacity needs to look like within our out of hospital setting, so that we can ensure that those patients that are sitting with the beds at the moment that need to come out actually are able to be discharged appropriately. It's an area that we've really got to do better with, absolutely. I don't know if Claire, you want to add anything in terms of the market management point.
No, other than that, it is work that we're doing again alongside local authorities to try and standardise our costs, and equally for some individuals who might be CHC today, but then from an experience and an outcome perspective, they improve and they're no longer CHC, that either if they have to fund their own care going forward, or if it's picked up by the local authority, that it's an acceptable cost, that it's not something that, you know, is extreme and that wouldn't be considered appropriate. So that's all part of that work. The only other thing that I would just add from that prevention perspective, that from my perspective is where you would hope that neighbourhoods will come in. So the bit that you're talking about, the numbers of volunteers that are available and how we support those communities going forward, that's exactly what neighbourhoods need to do and how we embrace that. I'm an ex-district nurse of years ago, but to me, you know, to hear that somebody's having to rush and they can't give the care that's needed, they're the bits then, and then when we talk about the ambulances and all of that, they're the bits that we need to get right, and that's what neighbourhoods need to do in the future. So it's really important that we do that in a real innovative way as a system going forward.
Thank you. I would defy any councillor around this table, any officer, to tell me of an organisation that is attracting volunteers and who have enough volunteers. For some reason, since COVID, we cannot get volunteers. People are so busy, the cost of living is so frightening. That's not your fault, but people are having to work longer hours to look after their families. So I'm afraid that I still am of the opinion that we are trying to push people out into the community. It's not going to work. Thank you, Chairman.
Okay, thank you for your question. Councillor Edgeler. Do you still want to ask? No? Councillor Kelly.
Thank you. My question's on prescriptions. So for a while, it can take people a while to get medications that work for them. It can take a lot of time and energy to do that. When you're now doing cost-effective prescribing, are you going to be taking patients off medications that are currently working for them to now put them on different ones? And how will that affect people? And then you've already been doing so prescription prior year effects. So have you got an understanding of what impact there has already been on the NHS no longer doing and how many people are affected on prescriptions? That came out wrong. I'll reword that.
Sorry, I just missed.
Can you help us?
The second bit of the question, yeah. If you could just... So I'll answer the first bit
first. It came out as word salad. I can repeat completely.
Shall I go for the first question first?
Please,
sorry. So there isn't anything in here that's saying that we're going to take people off medications that are working for them effectively. What we are doing is looking at those medications that are not improving outcomes, or I mean, we've talked about people on the sort of frail elderly people that we've talked about in hospital. A lot of hospital admissions are caused by polypharmacy, so too many medications, and focusing on that is so important because actually we put people in hospital with too many medications. So having a consistent review of people's prescriptions is really important, and proper medication reviews. And we come back to the R's roles. So we've got pharmacists working in general practice who are able to go through those medications, see where the interactions are, make sure people are on the right prescriptions. So it's about optimising patients' care and using the right medication for the right patient. Sometimes we might change medication if we've talked about the biosimilars, so they're exactly the same, but they are more cost effective, so they would not impact on patients. But again, you would go through a conversation with the patient, and it's those really structured medication reviews that are so important. So I suppose the pure answer to your question is no. But are we looking at people's medications and optimising them? Yes, we are, because people can end up in hospital with the wrong medication, and we over prescribe. We know we do. We've got to make sure that we empower people and we don't just go for medication, and we work with patients to optimise them, and that's the work we're doing, not just going, actually, you know, we're just going to strike that off. So that's not our approach at all. So that's your answer to the question. So please, second question.
Thank you. Sorry. That's actually very reassuring. Thank you. So what I was trying to say is, can you help us understand the impact of the prescribing prior year effect? So this past year, I can see that you've already made changes to prescriptions and how that's affected. I would just want to know how that's affected people and if you understand how many people it's affected. So you said oral nutrition and supplements, you'll be getting rid of those. Vitamin prescribing, you'll be getting rid of a lot of that. So how will that affect people? And how have you seen that it's affected people previously?
So I'll take the oral nutritional supplements. We've done a huge programme around this as part of the treatment of malnutrition. So we haven't just taken it as we're just looking at all nutritional supplements. We're looking at how to, again, optimise patients along that pathway. A consequence of that is that we are looking at the all nutritional supplements. We had some really sad cases of where people were just sort of dropped a box of the juice at the end of the table, weren't enjoying the social element of eating, really focusing on food first, really focusing on making sure that, you know, the recipes around fortifying drinks and people enjoying food if they can. So we've got loads of examples where people's lives have been really improved with that. So that's the sort of the focus is around outcomes. So I'm slightly losing the question now because I think I'm going down on the same route. But it's about focusing on the pathway and outcomes, and we have got a lot of data around that, which would support the oral nutritional supplements. Every bit that we look at, it's slightly different metrics that would show our success around it. So if we're talking about switching people to biosimilars, we would be looking to switch a certain percentage to them and working with our secondary care colleagues. So I think if we look at each line of this, it's looking at a different bit depending on which medication it is, which system it affects. We worked really closely with the oral nutritional supplements with our general practice colleagues around reviewing people that were already on them. And so that takes time. That takes, conversations with patients, carers. So that was the focus that we have around these. And we do have a number of sort of metrics that we measure around the number of patients that are being reviewed, the outcomes, etc., that we would go through that. So I don't think there's a simple answer, but it would depend on which line that we're looking at as to how that impacts. But, I'm a clinician. My focus is on outcomes and doing the best thing for the patient. And sometimes, like we talk about polypharmacy, we might see a reduction in the medication that we're using, but the outcome might be that a percentage of people are not falling in their own homes because we're dropping their blood pressure too low, things like that. So it's all about outcomes with each of these lines of prescribing. I don't know if that answers your question, but hopefully it does.
Okay, do you have any follow-up questions, Councillor Kelly?
So when you're giving people, when you're no longer giving people oral nutrition supplements,
Yeah.
you're now for clarity, you're now supporting them more in being able to eat, being able to enjoy those things, and putting more effort into that instead.
Yes, absolutely. So when we worked right across the system. When we tracked the use of all nutritional supplements, we realised that there was about 7 areas in the system where that they might come in. So whether it's care homes, whether it's general practice, it's secondary care. We've worked across the system to make sure that that we have one aligned approach to this, so that they start to enjoy food more. So they're within care homes, we did a lot of supportive recipes, so they could and we'd go into care homes to support them to how to do those recipes around some the sort of milkshake style drinks if they need that. But the focus really has been food first. If you're able to have food, the emphasis has been about enjoying that, making sure that people aren't isolated with a box of the ONS just sat on their tray. So we've worked right across system to support all areas, which has included places like hospices as well. So it's been a really interesting piece of work, because in order for it to work effectively and make sure the outcomes have been as best we can, we've involved all of those areas, and we've tracked it, and we've looked at the metrics, and we've supported it, and we've bespoke the advice depending on which area we're looking at.
Okay, thank you. Councillor Doherty.
Yeah, just to touch upon Councillor Kelly's comments there. I have worked in care for 7 years in a nutrition capacity, and it's easy to say that you can work around food, but it's not easy to try and get somebody to eat food if they don't want to eat it. My husband he had a heart attack in 2023, and the medications that he's on have altered his taste. He refuses to eat he won't eat meat, he won't eat a lot of things now. So those nutrition, and he used to have those, he used to have the 40 sips, but he's been taken off them, he can't have them anymore, so, and he's lost weight because of that. So it's not, I can't word it right.
I think words are loads catching.
Yeah. So my question is, are we looking at medications and how they affect people's taste, how they, to encourage people to eat food, we need to look at medications that they're taking, because they can really alter that. That's it, I'm finished.
No, I absolutely understand what you're saying, is that, it affects people differently in different illnesses, and they were given out for various different reasons. The important thing to say is this whole approach is looking at patients as an individual, and actually, we've as I said, we've got lots of really positive stories about food first, and the referrals to dietetics, as I mentioned previously, it's making sure the right people get to that advice, and it, in in a lot of circumstances, that's the most appropriate way to treat patients. So I wouldn't want to comment on individual cases, but the whole approach to this is making sure that patients are treated as individuals, that they have access to the right services. If they need oral nutritional supplements, they still are available, but they would be available in certain circumstances. And certainly most of the time, the food first approach and the right advice through the dietetic service is the right way forward, because, the availability of foods, and they can be liquids, the recipes are around fortifying liquids to make sure people have the right nutrition through that. That they, all of that information is out there. So, like I say, I wouldn't want to comment on individual cases, but the approach to the malnutrition approach has really shown a lot of positive outcomes, and the services are available to support people, and we've upskilled a lot of the system in how to assess malnutrition, which has had really positive effects as well.
Thank you for your question. Councillor Greatorex.
I've got a couple of spin-off questions from other ones raised earlier. Both Councillors Wallens and Norman have asked about the 95 million deficit. I'm just wondering if this, from what Phil was saying, if it's a bit like the national debt in sort of national level, that it's a regular thing that's always there in the background and never actually gets paid off. I mean, what's the arrangement in terms of the amount of loan, given that you've got the metrics going the wrong way and you've got a need to find savings in the budget? Is it something that's there in the background that is a millstone around your neck most of the time?
So, absolutely, yes. So when I said earlier about the changes to the NHS financial regime, if we deliver the plan this year and we continue to deliver the plan for the next 2 years, the historical deficit gets written off. We are confident that we have a route to get there for this year, as long as we execute all the actions that we need to execute between now and the end of the financial year. That millstone round our neck and the lifting of it will provide us with additional financial headroom in the next year, because we won't have to repay the deficit repayment, which this year was to the tune of about 11 to 12 million. So we are really focused on making sure that we deliver safe care for patients, but deliver it within the financial resources that we've got, so it enables the system to have access to a greater level of resource in future years.
Okay, without breaking any confidence, is it sort of level that you'd expect, sort of intergovernment rate, like minimum lending board and that sort of thing? Is that sort of rate of return?
Sorry,
The rate of interest that you're paying on, is it like a loans works board level, or is it higher?
No, it's not. It's not higher.
Okay. The other question, if I might, was a question about reviewing of medication, which Councillor Kelly had asked about. I just wonder how proactive the reviews are, without getting too personal. It seems to be that as you get older, you get more regular need for prescription. But it's very straightforward from my recollection that you get put on things, but you don't get reviewed off things very often. And I just wondered, speaking to the drug dealer that my GP practice has got, very keen to say, let's not review that just for now. Let's see how you're getting on with this next batch of prescription before you take anything off the list. I've got something I've had for some while, which I think should be coming off, but I was reviewed a couple of years ago, so no, keep on for the time being. Doesn't seem to be very often proactively reviewed.
So, I mean, medication reviews are really important, and they are very much part of good practice. Most people will have their medication reviewed at least annually. And again, I don't want to comment on an individual case, but that is the practice that we would be looking at for an annual review. Most GPs will call people in. A lot of them use the month of their birth date to call people in for those reviews. It depends on what you're on as well. So some people will need far more regular reviews on their medication, and it will be assessed on clinical need and clinical outcomes. So sometimes I'll have a patient that I see, regularly for a few weeks until they're stabilised. So that medication will be looked at more frequently, and a blood test might need to be required so they stabilise it. So it's very, very different. And again, it's about making sure that we review those regularly, but having the clinical picture that sits around that medication. There isn't an incentive for people to prescribe more than they should, but absolutely best practice is to make sure people have regular reviews to make sure the patient care is optimised, and have the conversation and the care with the patient.
Thank you, Councillor. Councillor Johnson.
Thank you, Chair. Going on to the national priorities, particularly health inequalities and the shift towards prevention. How is it being done? What are the practical examples of this, in particular in areas that are less well off and those sectors of the population that have greater health needs?
Sorry, if I start off on there, others may want to come in. So certainly the move to neighbourhoods within the 10-year plan is all about that prevention agenda, really keeping people healthy and well at home. And the method to do that is to understand the need of that local population. So where we're talking about a neighbourhood, we're talking about 30 to maybe maximum 50,000 people. And then the idea is that we have a deep understanding of that population health and then tailor the services that we deliver to meet that need. What I think that will ultimately play out as is there'll be a core offer, if you like, of what is provided at a neighbourhood level, and then there'll be an element which is variable dependent upon the need of the population. So some early moves around that have certainly been around our focus on long-term conditions and frailty. So GP practices, for example, will have lists of those patients who are known to them who are the most vulnerable. So it's about that those interventions, working closely with those highest risk people, if you like, in the very first instance. But as we move forward, it's going to be about designing those services that ensure people are staying well and being able to manage those conditions within the community. I mean, there's tons of examples when you look both nationally and internationally in terms of how this is done effectively. I was a few months ago down at the King's Fund, which is sort of national think tank essentially, and we were hearing from colleagues who'd done a really good scheme over in Alaska, of all places, but they were able to articulate how they had different care professionals physically sat around in a room reviewing that cohort of people who were the most vulnerable, and then between them deciding what the best thing to do is. And I think that's where we've got to aim to get to. I mean, my own mum, for example, is under about 5 different consultants and pathways at the moment. It leads to a lot of confusion, a lot of duplication, whereas I think having that holistic approach at a local level on somebody is where we've absolutely got to get to. So there are small examples of things that have been done in populations locally. There are really good examples nationally and great examples internationally, and we've got to, in the coming months, build those plans to deliver that.
Just excuse me, thank you, Chair. How will you gather that information you've touched on within the GPs and that? But how do you engage with the local communities to get that to?
Yeah, so it's a mix of what's termed as population health management (PHM) data, which provides a very detailed insight into the needs of the population, drawing data together from a vast array of sources, so both health and sort of socio-economic data. So it's using that, but then it's also through engagement with communities, talking with our populations really to add the richness to that data, and then work with people to design what works for them best. And that's again why doing it at that more local population level is more valuable than trying to do it on a much wider population of the 1.1 million across Staffordshire and Stoke-on-Trent. The other thing I would say, one of the benefits of our clustering arrangement is that within Shropshire they've been awarded one of the, I think it's about 40 or 50 odd, is it, national pilots for neighbourhood implementation. So we're going to be watching that very closely to try and draw out the learning from that to be able to roll that out across other parts of our geography as well, now that we're a cluster.
You touched on what I was going to say. I was just going to add really the bit around the individuals themselves in the communities. It's really important that we bring that voice in and we make it real and you know, genuine, and that we respond to that. I think that's been difficult when you try and get that patient voice and the true representation of the population, but you know, that which Phil's just touched on really, about bringing that focus.
Thank you. Councillor Wallins.
Thank you, Chair. And it's just a spin-off question, really. I know many councillors, like Councillor Greatrix, Councillor Kelly, Councillor Doherty mentioned about prescriptions and so forth, but wouldn't you agree that using natural home remedies is the way to go? For example, like consuming more vitamin C, vitamin B, or eating stuff in high protein to prevent, you know, injury prevention or immune support and stuff like that?
So I think it would probably ties up with the previous question around prevention. I mean, I wouldn't necessarily be advising that we all took high dose vitamins. I think we need to be quite careful about that around only taking what's advised on the packets that you get. But it's about empowering people to live a healthy life, and that's the bit that is really important. So you know, we've got a really high rates of diabetes, you know, we've got high rates of obesity, etc. in this area. It's about supporting people to live the healthiest life that they can, and that really fits in with the prevention agenda. It also fits in when we were talking just about it around preventing people progressing as well. So if we think about frailty, we know we categorise it as mild, moderate and severe frailty. What the really big thing for us is to prevent people, first of all, becoming frail. So, you know, making sure people are active, you know, the working with people around strength and balance, etc., around those communities, and really trying to improve people's health so that they don't progress to moderate and severe frailty. So I think there's a huge piece of work around in the neighbourhood agenda around supporting people to live the healthiest life they can, because we're talking about healthy life years, not just life expectancy. And there's a lot of improvement that we could do there, both locally and nationally, about healthy life years. I think that's a really important focus for us, so that we all live healthy lives as well as longer lives, and prevent that. We talk about sort of the ageing population, but if we can support that population leading healthy lives, that pressure on the NHS and other services will be less. And given the ageing population, it's really important around prevention and living healthy lives and healthy life years as we go forward. But I would go with some caution about lots of vitamins and specifics about diet at the moment.
Thank you. And just one more thing I'd like to ask. And you mentioned there's an increase in diabetes and so forth. I know you can't help type 1 that's genetic and type 2 you can prevent. You know, when it comes to people who are type 2 or on the verge of type 2, you know, they may look to get type 2 diabetes, to potentially looking to get free dental care. I wonder, how could you prevent people from obviously getting into type 2 diabetes? I know why people may do on a deliberate basis to get free dental health care, but what's the deterrent to prevent that statistic from going up?
So do you mean the diabetes or the... so there's lots of... As you know, from a dental care point of view, there's lots of work that's been done in the... So we talk about primary care, and obviously dental fits into that primary care that we look after as well. So we work very closely with our dental colleagues over the county around some of the urgent dental activity, and there's lots in place around maximising the use of that, and primary care colleagues would be able to give you a bit more detail on that. I haven't got it to hand at the moment, but we work very closely with them to increase that. It's slightly separate from the diabetes conversation. I mean, clearly there's lots of work we need to continue to do around supporting people so that they don't progress into type 2 diabetes. A lot of it can be reversed. We've got the national prevention the programme around that, and there's lots of other things that we're doing around weight management with the communities as well, and that fits in very much around the agenda around prevention. So the dental element of it is absolutely, we need to continue to improve the dental outcomes, and again, it's probably information that I'll be able to give you around the use of that dental activity, unless Claire wants to come in on that.
Chair, I was just going to ask in terms of the length of the session, simply because I know some colleagues have got other commitments to get to, and it didn't detail it on the agenda, so...
Okay, generally, the meeting does run until 1 o'clock. So, who is it that... So I think we've just got one more councillor that wants to ask questions.
Okay, all right, thank you.
Okay, Councillor Griffiths.
Thank you, Chair. And as normal, the committee have asked all the questions. And probably the only reason this question hasn't come up is the focus of this meeting has been the £83 million saved from the 24 projects. So perhaps this is something more for a future meeting, but the NHS trusts have got to save £136 million. So I was wondering whether very briefly you could answer how that is going to happen, or perhaps that would be something you could bring to us at a future date? Thank you.
That's probably more appropriate for the NHS Trust to bring to this committee at a future date. There is a wide range of schemes that the organisations are working on. One in particular actually links to urgent and emergency care, and we've spoken about earlier in terms of those patients that we know should be discharged and are actually being cared for in a very costly acute setting, when actually it's more appropriate that they are within a setting more appropriate for their needs. So that there's a wide range of schemes that all organisations are working on, and it's probably appropriate that they come and describe those to you.
Thank you for that. So thank you to come in. I'd just like to say quickly, I want to give a special thank you to Tracy for all the help that you've given. I understand this may be our last meeting together, so I just want to show my gratitude to Tracy Shewan from the ICB for all the help that she has given to me personally in the last 5 months, and to the committee for, how long is it, Zach? Throwing you on for a while, for quite a while. So thank you, Tracy, and thank you for the rest of the officers to come in. Thank you.
Thank you very much indeed. Thank you.
So we're going to move now on to part 5, which is our work programme.
Yeah, good afternoon, Chair. The work programme's remained reasonably unchanged since the last meeting, but however I do note that there's been a couple of resolutions from the previous item about a few more items coming forward, so that will be updated then into the next work programme that comes forward. Thank you, Chair.
Okay, thank you very much. So I think that is everything for today. Oh no, Councillor Norman.
Well, we're not clear. You're not going to try and fill this Monday the 23rd up just because it's there, are you? I mean, if we've got nothing, we ain't got to come, have we? So I'll just leave that there. Zach, don't worry, through you, Chair. On the 23rd of March, I might have to email you in case I don't make it till the 23rd of March. Is that okay? Will you promise to answer my questions though if I email them? Thank you. Thank you.
Yes. Oh, sorry. Councillor Jones.
Thank you, Chair. I noticed we've got, further to the last of that I wrote to you last week, I noticed we've got primary care on in January. Are we going to be able to try and get some dates out of them for the MRU and UTC programme that we're still waiting for, particularly for leak? And also with the, I noticed we got rural pharmacy provision as well. That's something I'm quite keen to do. Pharmacy. Provision, which is a sore topic as well out in the rural areas. So I just wonder if we could, as I say, further to the letter that I sent to you, can we perhaps push for get some more information out of ICB on both those matters? Thank you.
Councillor Brown.
Yes, I agree. That was one of my questions, is the urgent treatment centres. But could we make sure that when whoever comes to discuss the primary care and urgent treatment centres actually outline what they are and what they're going to do? Because a lot of urgent treatment centres, they don't receive emergency, like things like chest pain, cardiac arrest. So I think it's really important that they outline properly what areas and what subjects they're going to cover so that people understand properly, please.
I'd just like to say that the ICB have assured us that as soon as they have more information on the UTCs that are coming forward, that they will give us all that information in the future. And I've also asked that they give us each UTC and the breakdown for which is going to have what provisions. And as for the MIU in leak, are you on? Is that what you're?
Yes, that's specifically a particular area of concern for the moorlands, the MRU and its threat of closure. And there was the last statement that we had from the ICB on that was that it was more public consultation might be needed. Well, if that's needed, let's get on with it. It's been going on for about 18 months, this has, probably longer. So I think we should be really pushing them, Chair, to give us some detail, if we can, please.
Okay, yes. actually, our councillor for the Moorlands has some, also is extremely interested in that, and she has been pushing forward for those things. If she'd like to give her input on the MIU.
So, I have asked about it a lot, a lot. But what they have basically said at this moment in time, there is no discussion going on about the cost bill to remove anything at all from there. That isn't even a conversation at this moment in time, that they will be removing services from the cost bill. As of the urgent treatment centres, I've heard the same exact information back, that when they know, they will let us know. But at this moment, they are still waiting to determine that. Thank you.
For me, though, Chair, but what's holding it up? It's been going on for ages, this has now. And it's the uncertainty that people don't get. I mean, Councillor Kelly was at my meeting last week, and she knows what the passion was like in that meeting. We need some answers, and we should be really pushing a little bit harder, I think, Chair, if we can. But
We have been pushing extremely hard on it. I can assure you that we are not sitting back, that we are pushing forward, and so is Councillor Kelly, as I can assure you, Councillor Kelly has definitely been pushing forward. So I would like to hand you over to Zach for this one.
Yeah, I was just going to clarify a couple of things. One of which is our understanding from what's been reported to us from the ICB is kind of the expectation around urgent treatment centres has changed from NHS England, which is what caused the delay, because your urgent treatment centres first came to committee in July 2024. But since then, there's been some national changes, so I think they're sort of still working that through. When they know, we will then know. The other thing, just to clarify, so in January it was going to be about the primary care, more so from GPs, less so about urgent treatment. That's not to say we can't ask the question, but it's just to be clear, it's going to be more about the general practices rather than the MIU at Leek.
I always get it wrong. Yeah, thank you, Chair. I'm not suggesting for a minute that we're sitting on our laurels and just accepting what they say. Just saying is, let's keep prodding them. And I'm sure Councillor Kelly's doing that, but I think we really need to give them... I mean, it's been going on for a long time, more than a year, and it's just the uncertainty, and people are really upset about it. So, thank you, and thank you, Councillor Kelly, for what you're doing.
Obviously, it's not my area, but I'm really passionate about this sort of thing, having spent a lot of years in it. I just think it's really important that when the time comes, and probably that you could ask for the information sooner, is what is the daily figure of attendance in their minor injuries unit over the last, say, 12 months, because that will reflect how it's currently being used. Whatever is going through consultation process and what they're trying to get out of people is how many people are currently attending on a daily basis will reflect, and the hours it's open will reflect how many people are really wanting it at the minute.
Yep, that's a very good question indeed. And I personally think that rerouting the ambulances to other hospitals will obviously also affect that as well. That number in and of itself, when they reroute to Stoke, it's obviously going to affect the usage of urgent treatment and for A&Es in the surrounding hospitals, and obviously make it look like they are lesser used than they are. So,
with respect, Chair, the ambulances that will be diverted will only divert currently, and it's something to ask, will only be diverted if they're of a clinical need and need to go to an emergency department. Otherwise, I'm unaware that they'll be moving them just to lower the figures at Leek. They'll be doing the opposite. They'll be taking people to Leek if they're of a lower standard grade than is required at an emergency department.
yes, we need to wait on, obviously, the information for the UTCs and to see exactly what's going on with the ICB and that information. So if we can sort of, we'll obviously keep asking them, and as soon as they know, we'll know. As soon as they know, I will make sure that we all know what's going on.
Chair, perhaps we should be just saying, when can we give us a date when you can give us a date? That's all we want.
If I could magically pull a date out of a hat, I really would. But obviously, I'm not in the ICB, so I can't give you that. So, unfortunately, although as soon as they give me a date, I will then give you a date. Okay. Thank you for that. Thank you for everyone coming. It's now 12:15 and it's time to close the meeting for today. Thank you.